Hi, I'm Avik Dandapat and I'm happy to present one of our challenging case. One of the lovely features of what we did was using modern techniques in implant dentistry. We were able to take a CBCT scan of our patient, as you can see here, in our in-house scanner, plan some immediate placements of implants, restoring the patient's back teeth in the upper maxilla actually on the same day with temporary teeth. And it's really amazing how implant design has changed over the years to enable us to get the primary stability that we need in very compromised bone situations. And as you all know, in the posterior maxilla, the bone quality is generally quite poor. With this particular patient, he presented with a few chronic periapical areas around the teeth and chronic infections. We were able to very gently remove the teeth, preserve the alveolar bone that we needed, as well as remove and enucleate the cysts that were present and place some implants around there. Interestingly as well, we engaged the floor of the sinus on the back implant in the upper right 6 area, and that is a cortical plate of bone, and we gained over 35 to 40 Newton centimeters of torque in this position. And we were able to give this patient a set of temporary acrylic teeth to bite on straight away to load these implants up. And it's really exciting how implant dentistry is moving forward with an improved design of the actual implants, and also with the digital technology that we're taking and able to scan the implant positions with support of great labs like Medimatch, and who are completely digital, and I can email them the data and I will get my bridge made from them within a week or so at a very high quality and high accuracy of fit that we don't have many problems with. And it was very exciting to show this particular case, and also some of the trickier bits of actually taking out a tooth, because dentists at the start of their career who've not done a lot of oral surgery will see that something that looks very simple, like an upper second premolar, which has got a root filling and needs to come out because there's not enough structure, and the actual difficulty of taking that tooth out, it's not as easy as it would sometimes seem, and the teeth may fracture and you may not get hold of it. And what I demonstrated today is, after many years of doing this sort of surgery, that even today it does take a little bit of time and patience and understanding on how to atraumatically extract the tooth in question, and especially on this particular case it was the upper right 5. So just to talk through what I did, I only engaged the mesial and distal areas of the tooth while always observing the buccal plate, because that's a very important structure that we like to keep. I also wanted to place the implants slightly palatally in the socket in the ideal prosthetic position, as opposed to where the bone would be. So the reason we're trying to now move to a much more screw retained kind of philosophy in our implant restorations, because we don't want to cement our implant restorations because of the potential risks of cementitis that basically occur. So you've got to consider all of these things in your planning by taking your CBCTs, by taking your study models, by doing your digital wax-ups before. So planning really is vitally important, working with a good dental laboratory who knows where things can go to produce you stents and enable you to put your implants in the position of the ideal position of where the prosthesis must be, not where the bone is in particular. And if there's not bone there, you've got to learn to put bone there. So we're really going to this idealist way of working. Unfortunately with this case, because it was immediate placement, we use the sockets as a guide, but sometimes we use surgical stereolithic guides based on our CBCT scans, and I've got unfortunate enough to have my own CBCT scanner and Trios scanner. We combine the surface data, the STL data, with the DICOM, which is the medical CBCT, and we produce a guide. It makes the laboratory's work much easier, it makes the laboratory work fit better, and it's generally a better restoration for the patients, and you have not got to worry about any cement around the tissues. So it was very interesting to present this case to everyone and have the team come down and record it. I hope you do enjoy it, and it has been a pleasure. Thank you. Alan, how are you doing?
Very well.
Great. Okay, so this is Alan, our patient for today, who's having some implants with me, and we're just doing some extractions on the top right of some retained roots and some teeth which have inadequate coronal structure. So Alan's under very mild sedation and we can talk to him. So you okay, Alan?
Perfect.
Yep, so Alan can talk to, and we're under a mild sedative. So I'm going to start by extracting the roots by just slowly breaking the periodontal ligaments between the tooth and gentle pressure on the actual root faces themselves. They're quite loose anyway, so just gentle pressure, creeping around with the luxator there. My nurse just aspirate so I can see what I'm doing. Yeah, that's the one. And we're just going to put some more pressure here. And the way we do extractions now is by time and patience, because what happens is when you place pressure on a tooth, the PDL will actually release hyaluronic acid, and that acid will actually help release the tooth. It's very important when you're doing implants that you extract the teeth without damaging the surrounding bone of the socket. So we want to use that valuable alveolar bone, because once that alveolar bone goes, it never kind of comes back, right? So we can already see we're getting a little bit of movement. So we're kind of leaning on this a little. So we're just doing the 4, and then just going to release there. And then one thing we like to do is just use an osteotome. I'm going to come in here, and my nurse is going to use an osteotome just to expand the ligament in this area. Is this all right? Yeah? Okay. Okay. Tap, tap. Tap, tap. Tap, tap. Tap, tap. That's fine. So we can engage the luxator on the root with a little bit of tapping, very mild tapping. Again, releasing that acid as we go along. And engaging that tooth to get a little bit more movement. So that little bit of tapping has made all the difference without having to drill away that valuable bone. So I'm just going to get a little bit more tapping now. Alan, little tap coming up. Okay. So, perfect, thank you. The retracted taps, and just a nice bit. So again, patience, time and pressure. Nothing's being forced here between these teeth coming out. Okay. That's awesome. So I'm still just leaning on that tooth, taking my time with that, just all from the buckle. Just clean that up. You can see a little fracture of the tooth there. Suction for me. Root forceps, please. Root forceps?
Yeah, got it.
Ah. Okay.
Oh, sorry, just pull it down.
Okay, so this is quite an infected site, so we're going to just going to deliver that. A little bit more manipulation. Fun, isn't it? How you doing, Alan? All right?
Yeah.
Well done. So I got big shoulders, you know. I'm lifting. You do boulders for shoulders. Alrighty. So we're just easing it now, not forcing anything. And then we're just going to ease up a little bit more on the root. Okay, Marzena, can I have the wider luxator now, please? That's fine. Yeah. Okay, still working on that. Planing. Okay, tap tap. So a little bit more tapping now. Okay, Alan, well done. Okay. Okay, that's fine. I'm going to rotate that fella. Real rotation. Nearly there, Alan. Yeah. It's all good. Right, and I'm just going to bring that, rate that papillae. Take enough time about that. There we are. Beautiful. Okay. So that's partially moving, root forceps. Awesome, thank you very much. Just a little wiggle. Out it comes by the other teeth. So that's the first root removed, Alan. Awesome. And we're just going to take the second one now. Let's get this fella. It's live extraction on TV. Okay, let's give that a little rotation. See if that wants to play. So often with broken upper fours, they can be a little bit persistent because there's not a lot of tooth structure around here. So I'm going to work on this a little bit more from the perspective of that part of the ligament. So I want you to just to tap that a bit more for me so we can go down the ostium. No more. Zimmer. Okay, hold it there. Alan?
Huh?
Just a little bit sharper tapping that I'm going to do now, okay?
Huh?
Just bear, yeah, so. No gentle female touch there. Okay. Got good solid Scottish bone here, Alan. So we're just going to expand that ligament. Okay. So what we do is this under local, and just move, move, move. Just hold and wait for that acid release in the periodontal ligament. You okay, Alan? Nothing's hurting, you comfy? Awesome.
Okay.
That's great. Okay. Let's clean it up, let's have a quick look at where we are. Can you grab onto that now? Thumbs up, but we'll see how we want to. Use the force, absolutely. The force of breaking like this does, we break it. Yeah, you got a good root canal, someone tried that, that's gone. Okay, have a mirror. So sometimes we divide roots up and we'll see what we got left. Yeah, okay. I'm going to reflect a little bit on the palatal, Bianca. And yeah, so I'll just reflect with the other luxator there. See if this wants to play. Okay. Let's take that papillae there as well to see. I'm just gently elevating the wee flap. See if we've got any more movement. Right, I need to get right down to that ligament. So a bit more tapping on this premolar. All the time looking at that buccal bone. You got it. You got it. Yeah, that's definitely better. Okay, so we're just gently expanding that root field. So I'm just taking my time over this extraction. We're taking ages. Right, and then it goes again. Right, so I might need a fast hand piece at this stage. So, okay, so we have a premolar that's breaking now. So we need to now divide the tooth up a little bit, right? So slowly but surely into this socket. And slowly manipulating that root still there. Till we should technically be able to deliver it now, but we'll see how we go. Sometimes it does, sometimes. So you note the most important thing here is we're keeping that buccal plate. I need that. It just helps. And then we're just gonna. You got a finer forceps at all?
Yeah.
Give me the baby. Yeah, we have the babies. Might be able to tooth this in. And just hold it. There we go. And we kept that buccal pretty much intact. Can you see that? Okay. So typically the difficulty of these sort of extractions is when you've got a very heavily root-filled premolar tooth. obviously it just cracks. There's not enough structural integrity to really grab hold of. So you just need time and patience. I don't know, it's just dropped, and you can get it out. So what we're going to do now, we've kept all the buccal plate, everything intact here. So we're going to get the patient ready for an implant to be placed in the fore area and a sinus lift and going in the back there. Okay, great, great. Okay, so now we've done the extractions of the first premolar and the second premolar roots. We're going to place an immediate implant in the position of the 4, and we're going to do a sinus lift in the position of the 6 and place another implant. So I'm starting off with a incision to slightly off the crest, going towards the palate. Alan, are you okay? And the incision comes forward. I'm using a double-sided blade. It's one Morton blade there. Modified Widman just to release the tissues. I don't like the relieving too much yet until I feel how the tissues are actually going to come off and give me the view that I need. What I'm using now is the AD Blackline kit by a company called Titan. The kit was designed by myself. Very nice periosteal elevators. A bit of pressure, Alan, and expose that bone. Exposing the palatal side quite simply that way. So I have a good overall view of that bone, and we have a little bit of an infection on the front there. Now, I don't generally like relieving anteriorly too much. Just like to do that. Alan, how you doing?
Yeah, good.
Looking awesome. Yeah, and then we're just going to see there is a cyst. So what we're going to do with the cyst is I'm going to ask my assistant just to hold out the retractor there, and you've got a separation of granulation tissue from the gum tissue. So I'm just going to gently dissect that away from the gingiva. So, and then you can see that granulation tissue emanating from that socket, and we are going to do some enucleation of the cyst using some various periosteal elevators to see the extent of the damage of that infection. So it's really important to remove this infection, especially when we're placing implants. You can see we've got it nicely enucleated in one go, and you can see it's an epithelial lined, probably what is a dentigerous cyst there. Can you see that on the camera? Yeah. And that cyst is all removed now, and we can now really visualize the remaining bone structure as well as the width of the ridge and the socket anatomy. You want a bite block? We can do with a bite block, it's fine. No, I think I'm okay. Now, in the kit itself, I have a long, straight probe, which is blunt-ended. I like to feel the anatomy of the socket, feel where the base of the socket is, and decide on the positions of the implants that they're going to go. And we know with the socket we have over 15 millimeters of bone, so we're placing a Megagen 15 millimeter by 3.5 into the socket there. We're doing an internal sinus lift, and we're going about 10 millimeters there. 5 millimeters till we hit the cortical bone in that position. We're going to try to parallel these fellas up. Right. So, what we need to do, I'll just triangulate this CT scan for a second. And you can see the root is slightly mesially tilted on there, so we're quite safe to go a little bit distal of the socket. So this is how we're going to play this. Yeah. Alan, if you could open a bit for me, buddy. How you doing?
Yeah, good.
Really good. Me too. I feel awesome. Yeah. So we're just having a little feel, a little clean out that socket. Job's a good one. Going 2.8 straight, drill extender. Just get me my drill. Okay.
Bit more. That's it.
Now, that's your root of your 3. You need the root of this is slightly mesally inclined from the CT scan. You can see my drills going to the apex. What we want to do is go slightly behind that, and then just start our drill, just to feel through that bone, just a couple of mil. Alan, how you doing? Good man. Okay. We use something called a drill extender, just to extend the drilling surface. Here, just get a little bit more leeway, a bit of sinkage. We're going to look in there.
A little bit wider, Alan. Cheers, buddy. Just going a little bit distal from that root. A bit distal. And I'm going to feel that sink it down to where we need it. Open, Alan. Thank you. That's awesome. So that's getting into the right direction. That's amazing. And we're just going to... Alan, if you move that slightly that way, cheers, buddy. Right. You've got the duck extender. I'm just going to hold that there. You pull that. Got it? Okay. And we're just going to correct that to that angle there. See, we're knocking that tooth. So common issue, long canine, you need to get deeper, you're knocking the tooth, yeah? So what you need to do is you then get back on that drill extender, get the patient opening wide enough to get away and get into that position that we want this implant. Implants are planned in the prosthetic. Open again, Alan. They really stretch you for a minute, okay? Try to get in the socket, position where we want to position, yeah? Check that all out. Amazing. And then we're going to go a countersink a little bit more. Cool. So there's a 2.8 drill. Really don't want to do any more than that. Checking where that crestal position of that implant's going to be. I'm quite happy with that. Open wide, Alan. That's where we're going to be. Awesome. Right, so guys, I need the implant now. So we're needing a Megagen 3.5 by 15, please. Straight in with a 2.8. So most with immediate placements is that you need minimal drilling because... Okay. Marge, can you fringe these figures to 70 on the bottom? Yeah, that's fine. 3.5 by 15 millimeter implant. Alan, how you doing?
Yeah.
All right, Alan's good. I'm good. Bianca, how you doing?
I'm good.
Well, everyone's good. You can see there the numbers.
3,
Nice. So that was
4,
now
7, 8, 12,
Mhm.
13,
Okay, well done.
19,
Great.
21, 25, 29, 32, 35, 44, 47, 49.
Indicated torque at 52 Newton centimeters. So the clinical evidence shows us that any torque over 24 is acceptable for immediate loading. We are smoking at 47. Yeah? Directional indicator. Open for me, Alan. First implant's in, buddy.
Okay.
Yeah, no. We are... Are we all happy with that? Okay, I'm just going to put the directional indicator on. Okay. I'm quite happy I'm away from the root of the canine and I'm going for the sinus lift at the back now. Really simple. Give me the measurement. Go onto that. Use the mouse. Go onto that space distal of the bigger defect. Yeah. Tell me what implant we have.
4.5 by 10.
4.5 by 10. Okay, so you've gone onto that space.
Yeah.
Measure that bone.
More like here.
Yeah, so what we've got is 5 mil, 7 mil stop with the gingival stop here. I want to parallel up to this particular implant here. I want to change mode. Correction, what was the implant again?
4.5 by 10.
4.5 by 10. Okay. Okay, we're going to go first marking at 7. So I'm just going to widen that osteotomy bit. How are we doing, Alan? Okay, second drill. Open a little bit wider, Alan. A little bit wider. So again, we've got drill access issues, so I'm going to come in sideways and then correct. Down to there. Perfect. So now we are at and sitting at the sinus floor, and we're going to do the rest of it with the aosteotome. And we're going to punch up through cord wire into the sinus. Okay, Alan, a little bit of tapping, buddy. Yeah? Might feel weird. So we're condensing the bone, waiting for it to relax. Change of tone. Crack open the implant. Okay, so that is solid Scottish bone there, Alan. Look at that. Yeah, you're good. Suction. Okay. Okay. That's the sinus lift done. Beautiful. Just going to relax that out. What you got? What you got?
Yep, 4.5/10.
Okay, 1 second. Let me check a 4.3. Okay, just checking depth. What we got? Here. Just get a 10 stopper. Easiest way. Okay. Have a wee little feel. Open, Alan. Sorry, Alan. Boom. That's no perforations. That's absolutely spot on what I wanted. Just do it, do it.
Do it.
Okay. Mode 3, placement. Second implant's going in. Sinus lift done. Another beautiful Megagen implant. I'm going to try to use my rings away. Yeah. And you can see how simply this will just find its way.
8,
Yeah. These would be big numbers.
14, 15,
Really gripping on.
19,
Mhm.
21, 24,
Mhm.
27,
Okay, don't worry, don't worry. Just tell me every 5.
yeah, 37,
Mhm.
44,
Mhm.
48,
Mhm.
49,
Mhm.
51,
Mhm.
52,
Mhm.
61,
60.
61, 62,
So you're getting these sort of torque figures off, and we're maxed out at 70.
70.
Okay, so when it maxes out at 70, you can hit 100. With this particular implant, it doesn't matter, and I'm going to show you how to now relax it to get that last few mil of where you want that implant to be. Okay, Alan, how we doing, buddy? Alan, are you there? Yeah, good. Hello, welcome home. Right, so we're just gonna. So I'm just going to relax that fit a little bit because it's nice and tight. So just going to take it out a wee bit. Just going to wait. Bone has the property of being viscoelastic, so it does adapt. And I'm going to go back in with this implant. Really nice and firm. I'm just a carpenter. See? There we go. How you doing, Alan? Mate, have you seen this? Look, it's solid. Scottish bone. It's beautiful. Beautiful. Right. So I'm quite happy with that. It's just crestal placement over there. Quite happy with the prosthetic position for a bridge. Open for me, Alan. And we're going to get me some ethos, please. So we're going to use a little bit of synthetic grafting. And see there. Oh, sorry. Just check our directions. And we're just going to build a little bit of bone in that region to build these areas up and support the implants in this area. So the girls are just mixing some synthetic bone material, and I'm quite happy with that. And open, Alan. Are you open already? You've got a little mouth, Alan. Okay. Open wide? Yeah. Okay. So what we're doing is just going to put some synthetic grafting, no membrane, over the whole area to support the tissues. And this, I also get an improvement of the biotype of gingiva. So when we get non-attached gingiva, actually the gingiva gets thicker. So as well as developing actual bone with this material, so it's resorbed completely by the body, it's synthetic, and there's no pigs in it, or cows.
Can't see anything out of
Okay, you will in a second, not a problem. Right, so what my lovely assistants are doing now is just retracting everything back, now using the ethos, And we're just going to inject it around. Do you want to put a temporary abutment on there or healing cap prior to that? Right, so put a little bit there. Can I have a... You get kind of two of the cover screws. I'm just going to put the cover screws on temporarily. We'll put this material, so... Well, you want to give me the temporary abutments directly. Whatever you want to do. Give me the temporary abutment. The titanium temporary abutment, yep. I'm going to do that. So a couple of temps on. And we can directly scan flag this using the Trios system to make our bridge in a month. Okay, hit me. Alan, you good?
Yeah.
Awesome. Open wide, sir.
Move your right hand down a bit, Avik.
Sorry.
That's it.
That's it. Just trying to block that in. Not opening much today. There we go.
That's a clear shot there.
Yeah, so just putting the temporary abutment on. I'm going to shave that down a little bit, all right? And then we're going to put another temporary on there. And we can probably put a healing cap on the back. Can you get me a wide bore healing cap? Thing? And then I'll just do the grafting. Couple of stitches. Jobs are good. Perfect. And just going to put this on. It's smaller. The beauty of this connection is that you can hold a healing cap and do this, and it's a Morse taper connection, and it won't drop. You know, so it's pretty secure. It's very clever invention of this system. There we are, and that's the healing cap on, followed by a little bit more ethos, which is the grafting material. Okay, I'm trying to get this totally in view. So this material I want to put in, can you grab that and put it into the socket please? Around there. So you can see this is filling the buckle gap, or otherwise known as the jump gap. And jobs are good one. Keep that going there. Now with ethos you can see it's a bit slumpy, so we're going to just set it now. So obviously this is going to dry that up. That's really good. It's your 50 pound shot or 50 Vicron. Okay, so now we're just going to gently put the tissues back. You can see no relieving incisions were made, and just close things nicely here. Perm sharp, yeah. Perm sharp 50. Right, and we're just stitching up now. Yeah. Here we have a closed loop suture holder using a 50 perm sharp. It's a nice antibacterial suture, nice small, and we're just being gentle to the tissues, bringing them back in. Is that through on the palatal? Confirm. Beauty of this material is no membrane, no faffing, and we've just done a beautiful sinus lift and two very solid implants. So Alan, I reckon these will be ready and cooked to completely restore in 5 to 6 weeks. It's literally the time.
Okay there, Alan.
Alan's having a nice Scottish snooze.
Yeah, okay.
One too many
lovely.
beers. You see, I just lost a little bit there. So I'm just going to take that across. Wait. It's quicker than your composites, Alan. Yeah, you do a blinking molar composite. You guys take hours polishing. That's why I would have no patience to do that. But I like looking at it. It is artistry. Art in surgery. There we go. So we're just going to set that stitch there. You're going to cut that for me. I'm going to probably set that now anteriorly on the papillae. You want to turn it towards you. Turn towards the anchor. Get my surgical line. So I just want to get that papillary form to face. I'm going to need a mirror because I can't, the camera's in the way to be able to. Thank you so much. Wow. Oh, I'm through. Alan, deep breath for me, sir. Breathe. What's the SP reading, please?
You are now
97.50 now.
Just press the thingy much.
Well, it's just it's a mild bradycardia because Alan's very fit. He's got a nice low heart rate, which is good.
Just leave 1 sec.
Oh, together. Okay, so what we're doing is a vertical cross mattress now, just to hold your papillae up. And the papillae should nicely form anyway there. Okay, and there we go. Just tie that off in this direction. Just one more going across there. Perfect. Good. Set alarms. Cool. So I'm going to go either side of that healing cap, Bianca, as a H horizontal. So we're doing a horizontal H. Just one continuous. Just to take it around here. And you're going to get me some hemocollagen, please. Yes, Bianca? Hemocollagen. Let me pull that out. There we go. Beautiful, beautiful, beautiful. And then that's coming that way. Let me just tie that off as almost like a socket. How you doing, Alan? Still with me? Awesome. Sorry to disturb your sleep, sir. Just, pleasant dreams, sir. Great. Right. And one more little stitch. I'm just going in this way before I give Alan a little well-deserved break or snooze, whatever you want to do, buddy. Okay. There we go. Don't think that's through. Just to seal that. There we go. This loop. Is that closed? Good eye, mate. Yeah? Awesome. Just checking. Maybe one more across there. So? Okay. Last stitch on this side, Alan, okay? We're home free. I know. I clocked that. All done. Okay. So, Alan, that side's all done. Your sinus lift is all done. Very happy with that. And that's going to come out.
Great.
And bite together for me, sir. Good. Open. I'll move that out of the way, but I want you to bite on this gauze for the minute, okay? Open wide. Great. And bite.